and it kind of looks like a quilt in some ways, but it right away is so visual, and the person can see it and say, oh my God, you know, it is, I am getting really tired after this activity because I'm not stopping to rest. You know, so that has been very helpful to a lot of my clients to actually see it.
I think it's also important too, because my mom is always surprised when she gets tired and she could do half of what she used to could do. She always says, you know, of course I'll bake 5 cakes for the bake sale, and you know, I'll be there for 12 hours setting up. And she used to be able to do that, and now she can't. And it's always shocking to her when she's like, you know, it took me twice as long as I thought, and I forgot at the end, like the last 2 cakes, I left out ingredients because I wasn't able to pay attention. So this would be a good opportunity for me to have that discussion with her of, it seems like you have 5 good hours during the day. Is that enough time to accomplish this, or can we look at modifying some of those things?
What's important to you? What's the most valuable to you to do that day? And so, of course, you want to prioritize that.
My mom, I gave this analogy to her, and she has used it ever since in explaining to people why she can't do stuff. And she says, everybody gets 12 spoons in their day, and they can spend 12 spoons however they want, and I got 5. So I gotta spend my spoons on the most important stuff to me. I just don't have a spoon for that right. And so she's been able to use that when people ask her to do things, because she's super creative and she's super talented. And people want, they're like, hey, can you come and design my whole wedding and set everything up? And she's like, I don't have a spoon. So you have to, that would be one thing. Now, I don't want to neglect a holistic approach. It's important to get the psychosocial view of pain and to use these assessments to do that. But what are some of the biomechanical things we would also assess with? Range of motion, how it impacts that. What else?
Body mechanics.
Yes, body mechanics. Yes.
Doing things.
Is it working?
Yeah, if you do that, your computer,
Yes.
just sign in and to your Zoom and record from there.
So where will this record?
Well, it's gonna record in the cloud, but you're the owner of the meeting,
Okay.
and I'm signing in from this site, so you need to do the record.
Okay, I'll do that. And will she be able to pull up the PowerPoint from there, and it will pull up as well?
Don't we share it?
I had to reset it, so is the PowerPoint in here?
Yes. It's in Canvas. You shut down, then you.
I had to, yeah. 'cause
If you open PowerPoint though, it will,
There you go.
Pops it right up.
So,
So we talked about range of motion, we talked about body mechanics, functional use. What else do we do? Remember what I told you, it's got fluffy ears and fluffy tail, but the answer is always occupation. I told you that. It says, doesn't matter what I describe. If I say, what has big ears and hops and a fluffy tail, the answer is always occupation. Okay, it doesn't matter what I'm describing. So what do we assess when we're assessing pain? Always occupation. What their current occupation is, what their previous occupations was, how it's changed in recent years, what their priorities are. We need to know about occupation, all right? So no matter what we're assessing, that's number 1. Then we want to look at range of motion. Then we want to look at posture. Then we want to look at body mechanics. Then we want to look at the activity. But we always what? That's what occupation.
And,
Also.
and within that, what I find is with my clients, sometimes the occupation, the only occupation or occupational role that they have is being a pain patient. That becomes their entire life. It's going from appointment to appointment or putting occupations on hold until I get better, until I have this next procedure, and maybe that will be the miracle cure and I won't have this pain.
Yes.
So it's really important, as Professor Bona said, to start out with occupations, and that would give you a whole view of what's really going on. Whereas a lot of people do a reductionistic way of looking at it and start with the range of motion. And you may not even have to look at range of motion. You know, if you look at occupation. So we're going to starting out with, I have a case, actually, an evaluation that I did for several physical therapists of a client. And once you come in, it's a lot to read, so I just scan through it. And then at the bottom of the part one is.
Self-report of the client.
In priority, you see the direction on the bottom.
All right, so we'll say it again.
And you'll see from this evaluation, I followed the OT practice framework, and I put definitions in that, in the evaluation of each of the areas. And I do that a lot, especially when I'm working with a new client, new referral agency, because I want them to understand what I do and the language that I use as an occupational therapist is very different than their language. And so in my evaluations, I'm even trying to educate them about what's different about me. So we look through that.
And you should be familiar because you have your tattoo with the framework, right? It's something on your body.
closer for to pick me up?
It's doing a good job.
But you know how softly I speak sometimes. So let me know if I talk too softly now.
It's hard for me to perceive it because I muted it, but I think we're okay.
A lot of information there, I know. I want you just to jot down what you think you would do as interventions. In an order of priority. A couple more minutes. You know, because of time, I feel like we need to go on a bit. Before we talk about the interventions, what do y'all think, what were your thoughts as you were reading through this evaluation? First of all, what do you think about the evaluation itself? As an occupational therapy evaluation? Were there any surprises to you? Not the content, but the process of the evaluation. The things that you thought were done wrong. What did you think about this evaluation?
It's very thorough.
Yeah.
I mean, a lot of just on the beliefs and that was.
What you would think to put that in?
I guess not with that much detail. Like a lot of beliefs, there's like a lot of points on that. I would like to put one or two, but that was very detailed.
And
followed the framework like very well. Like we talked about all the areas of occupation and define them prior to going into applying like interview information to those areas.
Any other thoughts?
I think it would be easy for someone that's not an occupational therapist to understand.
That's good, I'm glad to hear that. So what interventions and priorities that we should do? Do people come in?
I didn't write it down. I didn't get that far, but, it just seems like a lot of his, decisions and his occupational performance is driven by like, extreme thinking. So like, he seems to be really anxious about the things that he does and so it would definitely be something that's like, I guess looking deeper into why he thinks that way and then maybe trying to negate or restructure the thoughts.
Very good. Everyone else agree that those, his thoughts, his beliefs, and his values affect all of his occupations, and that's the primary area that affects all of his occupations? You guys are really smart. Really smart. So we're gonna be talking about some interventions from OT standpoint with people with persistent pain. Just so you know, I have persistent pain, so that's why I'm sitting. I can't stand for long periods of time, so I just want you all know that. And I don't know if Matthew said that one of the reasons why he specializes in persistent pain is because of me. Watching and growing up with a mother who had persistent pain and a grandmother who had persistent pain. So it's very personal to him, and personal to me, working with other people with persistent pain. So when I started to get into this area, and let me say too, right now, you all kind of heard, I just retired from teaching. And what I'm in the middle of doing is setting up my own practice, an LLC, called, hopefully they accept the name, Meaningful and Productive Living Therapy Services. And I actually started the CPL. I developed and started the CPL. So as Professor Bonner said, all of my focus in my career, even when I worked in the hospital setting, I always have worked in community settings. I've always gone ahead and done that. So right now, what I'm doing is I'm seeing individual clients, and I'm doing private pay only. And as some of you may know, psychologists and counselors, most of them have gone to private pay only, and people seem to find a way to pay them if it's worth it. And people find ways to do things. So I'm trying to see what's possible here. And one of the reasons why I'm doing private pay is because if I were to do like Medicare, I couldn't leave the facility. I'm going to people's homes and I'm going out into the community with them. I'm going wherever they need to go. There's a client of Matthew's that he wants me to see that I met with him, and one of his hobbies that he really wants to do is he likes to go to the gun range. Well, there's a problem with accessibility for him to get into the gun range. And so one of my times with him is I'm going to go on the gun range. I'm going to go wherever he wants me to go. So I don't want to be limited by third-party payers telling me where I need to go and what I need to do. So we'll see what happens. So just so you know. So we're very, very lucky. You may wonder sometimes why you can continue to be a member of AOTA. Well, AOTA gives us a tremendous amount of support and resources. And so I just wanted to go ahead and start with, when I, look up and I started working with people with persistent pain, my first thought was, well, what's out there? What's out there in terms of OT? And so I went to the OTA website, and in 2011, there was in AJOT, at the back of AJOT, there's the issue is, someone actually brought up, is OT adequately meeting the needs of people with chronic pain? That was 2011. Flash forward to 2019, and I know that Matthew discussed with you the opioid epidemic and the fact that even OT now has gone ahead and said, hey, we want to help. And the problem is that we still have a lack of evidence for occupational therapy practice. Now, most people, when they think of working with people with pain, they think of occupational therapists who work in what kind of settings, who work with people with pain. And, yes, certified hand therapists. And that's pretty much the dominance of the field right now is in hand clinics, and maybe expanded into functional capacity evaluations and work conditioning and work hardening. But there's also a lot of inappropriate, using inappropriate types of evidence too, is what was in this article about possibly using cognitive behavioral therapy, which we're going to talk about. And then there was a concern that there was an underuse of relevant kind of evidence like vocational rehab, fear avoidance model, which I've been corresponding with an occupational therapist in New Zealand, and she works with people with persistent pain, and they're way ahead of us. Australia is way ahead of us. I've been very lucky. She's been mentoring me some in terms of what she's been using, and she's been getting more into the fear avoidance model too. In 2015, there was a systematic review of OT interventions in chronic pain, and once again, it's not a lot out there. Really isn't a lot out there. So there is a fact sheet, occupational therapy and pain rehabilitation, and there is one of the sheets, AOTA, living life to the fullest, managing chronic pain. There are some CAT, critically appraised topic, for musculoskeletal disorders. And we see in these resources very much a biomechanical frame of reference only. A little bit of talking about psychosocial, but mostly biomechanical. And in terms of an article in OT Practice in 2016, a little bit of shift to dealing with pain as a psychosocial issue and cognitive perceptual factors. So it's encouraging. We are seeing a little bit of movement. Now, in 2016, Donna Costa, who is an OT that has done a lot of writing for AOTA, came out with an article in OT Practice about what's our role in countering the opioid addiction. It should be addiction, not addition. I wouldn't hate to be with addiction. And you can see from this list, it pretty much is into the biomechanical frame of reference. And some of the things that you all talked about when Professor Bono was talking about the assessments, biomechanics, what would you do in interventions, looking at posture, things like that, doing PAMS. Now, we are seeing some movement on looking at sleep habits, and OT is dipping its toe into dealing with sleep, and Professor Bono is actually doing, I don't know whether she told you this, but she's focusing on sleep as her capstone project for her doctorate. And when my thesis groups, my focus was on sleep and using mindfulness for sleep for survivors of domestic violence and people with persistent pain. So there are some, so in terms of the OT's role, in terms of if we were going to do an evaluation, this information was mostly taken from a semi-structured kind of COPM, okay? And what I have found is that I can kind of follow the COPM, but as a person who's a qualitative researcher, the conversation gives me all the information that I really kind of need, and I'm within maybe two visits. A lot of times I don't do the numbers. And there are different reasons why I don't. For my population at the domestic violence shelter, I found that the women don't really know what goes into performance. So they might say, you know, their performance in work, if they went and looked in the paper that day for a job, they would give themselves a 10 for their performance for that day, because they don't really know, you know, what goes into that. I have a client right now that you might get to meet that that I'm working with that had a spinal cord stroke at L1 about 7 years ago. She's 67 right now. She was an ER physician, pediatric ER physician prior to this. And I felt like when I did the evaluation with her, I just didn't feel comfortable using the number. I just didn't feel like she would feel comfortable. I just let her talk. She talked, even on the phone when I talked to her, they set up my first appointment, and she talked to me for 45 minutes, tell me what was going on. So I didn't want to interrupt her with the numbers. So, you know, that's something you have to decide. So there are different, you know, specific performance evaluations like the Pittsburgh Sleep Quality Index, which both Professor Bono and I have used for our study that looks at insomnia. Because sleep disturbances are present, they think, in 67 to 88% of people with chronic pain disorder. Here is your activity record that you just talked about. I make up my own. I take parts of it, and I ask for an activity, and I may ask for just the pain levels. Because I think it's too, like we talked about, I think the NIHAR is wonderful, but it's just too complex for a lot of people. And so, and too much for them to do, so I really would get it back. So I just want to focus in on, okay, so is there pain at the beginning and pain afterwards? And and then for me, as we'll talk about, I want to know what are the thoughts and feelings about it. Now there is one that Misericordia came up with called Ouch, CPQ, that asks open-ended questions. But it's kind of like you already do in the COPM, and then it adds in like what you traditionally see in PT clinics that draw in where your pain is, like the biomechanical. And there's a disability index, which is 7 areas. People, I hope I'm going to get that. Go again. Oh, it doesn't want to. So people go ahead and rate here how much on the scale of 0 to 10, a score of 10 meaning no disability at all, and a score of 10 says that you can do all the activities you normally would be involved with despite being disrupted or prevented by your pain. So they have here family and home responsibilities, social activities, sexual behavior, and self-care. I haven't tried this one. One of the issues I have is with the term disability. The connotation can be very negative for people, or some people might say, I'm not disabled. You know, I'm able to still work, or I'm able to still do this. Why are you giving me this pain disability? So that's kind of the downside of that one. The Westry Low Back Pain Questionnaire is used a lot by physical therapists. Some of you may have seen it. It has a lot of function in it. Has anyone seen the Westry? Okay, where'd it go? Okay, Amanda. I don't want to have to stop this. So I'm gonna go on. You guys can click on it. There's a Tampa scale of kinesiophobia, which is a fear of movement. And there's a fear avoidance belief questionnaire, which is, of course, what physical activities or what kinds of work would you avoid because you're afraid of pain. Again, I have not used these. I'm concerned about some of the terminology that are used in these. So take it with a grain of salt. Some people might be sensitive about the wording. There's the pain catastrophizing scale, and I haven't used that one because of the word catastrophizing, to be honest with you. I'm concerned about the person thinking that I don't believe him or her that they have pain.
It's so funny that they would use that wording. I mean, it's obvious of what it's assessing, but
Right, it is.
Do you think they just say, I'm gonna do this quick assessment on you, or we're gonna do this assessment and we're gonna go into the name?
is it labeled?
It's labeled pretty clearly as catastrophizing. And you can see there's definitions by the person who developed it as a multidimensional construct, catastrophizing of elements of rumination. I can't stop thinking about how much it hurts, or magnification. I worry that something serious will happen, and helplessness. There is nothing that I can do to reduce the intensity of the pain.
But they just needed a better word.
Right, and I think it's important to know these things. I think, it's a 0 to 4 Likert scale, but yeah, the wording would put a lot of people off.
Could you do it as a structured interview?
That's what I've done. And that's what, and I've also done it as like the one that I've done as part of the NIHAR, like when I have the thoughts and feelings, that's what I've gotten at, is people saying, I felt like it was never gonna end, the pain was never gonna end. There was nothing I could do about it. I wanted to kick myself for going out and doing this because now I'm in severe pain. Okay, I don't know if you can all see this. I'm really sorry. I tried to put it in here and it wouldn't go in well. This is a pain self-efficacy questionnaire, and I actually used this one recently. I have a client who is 79, and he lives in a retirement setting in independent living. And he walks with a walker. He's really bent over. With the walker, he has stenosis in his low back, and there were some issues about. I wanted to know like how he really felt about doing his occupations, and this is a self-efficacy, like how well he thinks about his abilities to do it in his self-efficacy. And so it's got things like I can enjoy things despite the pain, and actually. He came out, and this doesn't show the whole thing, everything he put completely confident, like 5, 6, 4, 5, 6 in most of the things, except for the one that says, I can do what I want to do without taking medication. And that one was a 1. So that told me a lot. He actually canceled his appointment. I saw him twice, and he canceled his 3rd appointment with me. And he's one of Matthew's clients. Matthew referred him to me. And we think that he went and met with his physician, and his physician said that he thinks he has another procedure that might help him. So we think that now he's going for the magic cure, another magic cure, and so he won't need occupational therapy. The other thing is, I think that I hit on some rough things for him. I think that I tend to be the kind of person that, as Professor Bono will tell you, people tell things to that they don't understand how they ever got to tell, why they're telling me what they're telling me, like even really shortly. And he he had told Matthew that he was having problems getting sleep. And when I talked to him about it, it really takes him at least an hour to fall asleep. So he told Matthew it was due to the pain. Well, I found out that it was due to the fact that he ruminates about, his wife unfortunately passed away from cancer 9 years ago. And he ruminates about, did he do everything possible? Did he do everything he could have? Did he make her really happy? And that's the real reason why he's not sleeping for an hour. And so one of the things, he's a devout Catholic, and so one of the things I wanted him to try, that he was willing to try, was to do the rosary before he went to sleep. It was very meditative. He wasn't open to mindfulness, not open at all. So I wanted him to try doing the rosary because he felt like that was meditative. And he said, you know, I never thought about it. I have two, and I never even thought about it. He goes, his wife's remains are at his church, and he visits her every single day and goes and talks to her where the remains are every single day. So I think he didn't want to talk about it.
So now he's like, what did I say?
Yes.
Yes, and
Yeah.
a little embarrassed.
Yes, I think so. I think that's unfortunately what happened. And see, Matthew, who even though you can tell he talks a lot, and his clients tell him a lot, this client never told him that was why he wasn't sleeping. So we, as a team, get different perspectives, and DOT different perspectives.
And while she's going on to this, Dr. Matthew and Robin, I'll designate for doctor and doctor, were interviewing a client in front of a class for us. And it was so interesting. The first question they asked, so this woman had chronic pain and she had a whole history, and they both knew her a little bit, but they said, okay, what's the first question?
She was my client,
She was your
long-term client from the shelter.
Yeah. And so the first question Matthew asked was, tell me about your pain. And the first question Robin asked was, tell me about yourself. And it was just two different perspectives. And so it was very interesting to kind of see the difference between the two professions and what they focus on. But I mean, they're both very valuable and very important, but it's a different perspective on them too.
Right, and also, and Matthew and I've had a lot of discussions about this. You know, physical therapy is very into the biomedical model. And we are too within certain settings, but in a community setting, I am very collaborative. I am totally, what you saw, the first thing I listed was what he said his goals were. Like, for example, with the client with the spinal cord injury, I went over to see her during her physical therapy treatment that Matthew was doing with her on Monday. And I wanted to see her walk. She walks with lost in crutches. She's in the wheelchair most of the time. And so I wanted to see her up and walking, so I went. And so she and I are next, my next session with her, we're going out to lunch. We're going to go in the community. She lives downtown to Decatur, which is really good. She can get around fairly well. But we're also looking for accessibility issues. One of the things that maybe she wants to work on is getting with the planner and talking about lack of accessibility downtown to Decatur. So, so Matthew says, okay, so now I want you, when you go to the restaurant on next week, I want you to walk in the restaurant. And I'm saying, well, she's going to decide whether she wants to walk into the restaurant. I'm not going to have her walk into the restaurant. She decides whether she walks into the restaurant or not. So, you know, there's a little bit of difference between how we, you know, look at clients. Now, I'm not going to talk about some of the intervention, and this is based on what's the evidence and what's out there in terms of pain science. And pain science has exploded. Mostly from Australia. You saw Tame the Beast. That is one of two people from Explain Pain, Mosley and Butler. I was very fortunate. Butler came over and did a 2-day workshop, and I went to Butler's workshop. Very vary from me. But the two of them have gone ahead and really pushed pain science. So in the literature, what they're showing is the first step that needs to happen with a person who has chronic pain is to educate them about the neuroscience of chronic pain. That people need to understand the neurophysiology. And I know that sounds weird because, you all just went through hearing about all the neurophysiology. You think, how could I have someone who not even have a background in neuro, to understand this? Well, there are things out there like Tame the Beast. That's why we made the video. It's for people with pain. It's not, of course, it's for us, but it's also for people with pain. The most important thing is to get across to people that, to switch their thinking, that pain, there are no pain receptors, that pain is a warning signal that something's going on. And to switch that whole view of thinking. So there are written materials out there. I'm sorry, I meant to bring the book by Lowe. I have it, What I Heard. His analogies are like you're the CEO of your body. He has like a business kind of analogy of it. You saw Tame the Beast. One of the ones I like the best, and I actually gave to this client, is Painful Yarns by mostly the one from Tame the Beast. It's his stories of going into the outback and into the bush, as he says, in Australia. And each of the stories has a moral to the story. It's like they start out and he's going with a friend in his car, keeps making a weird noise, and the friend keeps hitting the car, just hitting it. And he keeps saying, what's wrong with the car? Oh, nothing, it'll be fine. And he keeps hitting the car. And eventually, of course, the car breaks down in the middle of the bush, and there's nobody around. And so, of course, the moral of the story is, listen to the warning signs. If you are getting pain, pain is a warning sign. So that's the first step that you do. Traditionally, the interventions for OTs are the biomechanical, like we said. So people are still doing this. And I would add in job coaching and ergonomic assessments. Of course we want to do this. And when I was explaining to my client who I'm seeing, the one with the stroke, because she said to me, oh, and she thought she's a pediatric ER doctor, physician, that's her background. And she says, oh, you're like a life coach. And so then I explained to her, I went through PDO, and explained to her my background, and she's like, oh my God, that really makes sense that, I told her I do activity analysis, I have to figure out all the activities that she wants to do, and like, for example, she wants to sing, she loves to sing. And so she wrote down, she went in and contacted the Here Civic Chorus, which my family, my husband's family have been members of for years. And, he wrote that, pretty much we wrote down when problem solved, she couldn't think through. I said, you need to find out, is the building accessible for you to get in? Will they accept, which she knew, will they accept her sitting down during rehearsals and during concerts? Will they accept the fact that she's going to have to sit? For when they do the concerts, will they consider accessibility? When they go ahead and book the concerts. And so it just so happens that there's a lot of she went ahead and contacted the director, and there are a lot of people in the chorus who are older, and they actually sit a lot during the concerts and during rehearsals. So he said there's an elevator, so where we practice, and there's an elevator up to the second floor. And so he said, come on, we'd love to have you. So she just assumed that, but I showed her I have to think about all these, things that she wouldn't think about. We're going back. So what they have found is that pain neuroscience has decreased fear, and they have seen immediate effect of improvement of attitudes towards pain. So people actually feel differently. They've seen improved pain thresholds during physical tasks, outcomes of the exercise, and long-term the the effects. So there's been research done to show that that is really, really helpful if you would go ahead and do that. Now, here is kind of Robin's view of what OT's role is, okay? Things that I've thought about. And I don't know if we need to take a break or not. But, you know.
Okay.
No, okay, thank you. Thank you, that was wonderful. Appreciate that. What's the best way to get endorphins? What occupation gives most of the oxytocin? Has people secrete oxytocin?
There's a couple. Exercise.
Exercise. What else? Sex. One of the things that people in the beginning of our field, the very roots and basis of our field is performance of occupations and people feeling better from performance of occupations. And so the first thing that we can do is get people performing occupations. Like I said earlier, a lot of people, all they're doing is going from medical appointment to medical appointment. You know, when Matthew was referring clients to me, he's like, before I retired, he kept calling me and saying, "Are you sure you don't have time to see this person? All she's doing is going from medical appointment to medical. She's got nothing in her life. She needs occupational therapy desperately." You know, so people get back. My client getting back to singing. How much do you think her doing the singing is going to affect her? She has hip pain. So how much do you think it's going to affect her pain? A lot. Is she going to sing through the pain? Oh yeah, she's going to sing through her purpose. Exactly. The other thing is, and Matthew talked about sensory sensitization, probably thinking, what in the world? When it becomes where a person has pain over a long period of time, it becomes a CNS issue. And so, in that, what happens is, remember the allodynia? Well, people get hypersensitive a lot of times to touch, noise, bright lights. I have a lot of people, say turn on the lights, medication, high and low temperatures. Who does sensory integration? Occupational therapists. Are we doing this with people with chronic pain? No.
I had a young woman who, I think she had her first back injury when she was 16 and ended up having to do homebound because of her pain. And everyone wants to help her because she's a young girl with chronic pain issues. So someone sent her to a massage therapist. Well, she has central sensitization. The person, because somebody had gifted this to her, sat there with almost sweat pouring off of her as someone is touching her and massaging her back because she didn't want to hurt their feelings. Mm-hmm. And so she couldn't walk for 2 days after that because of a 1 hour massage that somebody thought all you need is just to relax, or all you need, but they didn't understand central sensitization. When I explained to her what that was and that she has to be protective of letting people touch her, she almost cried because she felt like something was wrong. Mm-hmm. So it's important to understand these concepts that even when you're mobilizing people and things like that, you have to be very careful.
That's happened to me too. Mm-hmm. Even by some massage therapists, people that are even licensed massage, which I see massage therapists now who understands this concept. Mm-hmm. But I can't even, I have allodynia and I cannot wear certain pants on my legs, like the spandex. It's too tight on my legs. I can't stand it. I just can't. So even dressing can be an issue for some people. Clothing.
Waistbands, clothing.
Right. My mother-in-law ended up, she used to wear pants and she stopped wearing pants because she just couldn't stand anything around the middle, so she wore dresses. But it wasn't any waistline. So we have some desensitization techniques like contrast baths, deep pressure, for sensitivity to light touch if they can tolerate it, and different textures, looking at the textures. Now, I know Matthew said he touched on this a little bit. OTs are not really doing this. I've seen only one article so far by an OT talking about doing this. But this is when people have central sensitization, this is the protocol for working with them. And unfortunately, what's happened is a lot of physical therapists who would be doing this, they don't have time. They're so busy trying to decrease pain that they don't get time to do this. Or I even said to my physical therapist, wasn't Matthew, I said to my physical therapist, why aren't you doing greater motor imagery with me? He said, well, I thought you had central sensitization, I would do it. And I realized he never asked me about any of the symptoms of central sensitization. So he didn't know I had it. He just assumed I didn't. He also, on my third treatment with him, I said to him, what are my goals? Because he never asked me what my goals were. He told me what my goals are. Well, he's not my physical therapist anymore. So they're greater motor images where you're actually trying to change the brain. This is a way to try to change the brain. And so there are 3 steps that you do. And the first step, so you're trying to get into the primary somatosensory cortex. And that, when you did the homunculus and talked about smudging, you're trying to actually change that back. What you're trying to do is get rid of that now, the back part is huge in my brain. And so the first step 1 is it sounds weird, but to work on laterality. Remember what laterality, left-right discrimination. Okay, so for some reason they have found that people who have central sensitization and persistent pain have difficulty with laterality. Something happened in their brain where they can't tell left or right anymore. Well, so here I have, so they want an accuracy of 80%. You show people pictures, so I've got some pictures. It's supposed to show it for like 1.6 seconds for neck and back. It actually has the normal responses. Okay, left or right? How many people say left? How many?
Well, I almost went left, but yes, after realizing I was.
How many people say right? Yeah, that's right. Left or right?
Right.
Right. Left or right?
Well,
Very good. What can none of you have persistent pain and central sensitization?
I don't have pain, but apparently I have poor laterality.
My husband doesn't. He doesn't have pain, he has poor laterality too. And topography. Yeah. Okay, so step 2 is motor type of the imagery. That's where you do actually imagining and rehearsing moving your limb or moving the painful part. So you think in your brain what you're going to do before you do it. So what the studies have found is that people who do that, and you can do this with people with strokes, with people with other disabilities, that it actually activates the part of the brain that has the movement. So the person begins to go ahead and desensitize those parts, and so they start to visualize. So we can have people visualize, okay, before you do this painful type of occupation that causes pain for you, like bending over, whatever, let's visualize it first, and visualize it without pain. Or you could start with just the movement. Let's start with one movement, and then start adding in. And so that can make that's supposedly, according to studies, have made a really big difference.
And then do you, like, when you're going through that process and then when they develop pain, how do you work with that?
You stop.
You stop. And then you might visit it the next.
Exactly. Yeah.
I've done this in acute care, even with my post-surgical patients. So day one, post-surgery, you're supposed to be getting up out of bed, doing occupations, things like that. And when those people who are in such intractable pain that you can't get them up, I use my OT session to visualize and to prepare them, because a lot of times there's a lot of anxiety related to it too. And, I know this sounds silly, but there's a lot of research that supports it. So even in the fact that it's not to the point, usually what happens is it's a person who's had chronic pain for a long time. They've had a surgery, and they thought they would wake up from the surgery doing jumping jacks and cartwheels, right? They thought that that was going to be the magic bullet. And when they wake up in more pain than they were in, it is very emotionally traumatic for them. So just doing the visualization has been a big thing for them, just to be able to improve participation. Usually at the next session, they're ready to go.
Now, a lot of places before you do, it used to be before you had a total joint replacement, like a total hip, a total knee, they would come in ahead of time for the surgery, and OT and PT would meet with them, and they'd go over, how things are going to go and what you're going to do for walking. The PT and the OT would say, here's a long-handled sponge, here's, what you're going to need, a dressing hook, and they used to go over it. Now they just hand it kind of time-wise. And so I always thought that if we went back to doing it ahead of time, then you could say to the person when you're there post-op, okay, let's go back to when you practiced it before you had the surgery, and remember what you did. But unfortunately, some of the reimbursement has made it such that that's no longer happening. Okay, so the third step is one that you may have heard about for amputees, for phantom limb pain, which is mirror therapy, where you have the person go ahead and put the affected extremity or affected part into the box, or you can't see it, and they move the non-affected side to feel like the affected side is actually moving. So you get the feeling that you're not experiencing pain while your other side is moving. Another type of intervention that's been shown to be helpful with people with pain is mindfulness meditation. How many of you have done mindfulness before? So mindfulness meditation, for those of you, I'm sure people are familiar with it too, is different than regular meditation in that the point of it is to be present in the moment, meaning to go ahead and work on stopping all the thoughts that go inside your head. It's a really good technique to do for studying, to relax your brain. Like when you just can't get anything else in. And also if you're really anxious about the test coming up and you just can't think straight, is to do mindfulness because it helps clear your brain. So it can help people with pain exist with the pain. And not make it something that you have to do something about right now. Okay, I'm having pain. I don't have to do something right this moment. Because as soon as you have pain, you start to have the anxiety go up, what's going to happen, the pain level's going up. You have a cycle. So it also can help with negative body image. It's been shown to work with mood disturbance, anxiety, depression, which depression is very highly correlated with chronic pain. Drug use to manage pain. They're showing studies now for decrease the opioid. I went to see my pain physician. I went to see the nurse practitioner actually last week, and she told me the DEA came in and told them that the CDC has come out with recommendations for the pain medications now, what should happen. And unfortunately, the DEA is not receiving it correctly. And they're going to all the pain specialists and they're telling them they have to wean everyone off hydrocodone, fentanyl, and all the other kinds of medications that they're handing out. Like all of a sudden, people just supposed to have been on these medications for a long period of time supposed to be off.
I had a patient who went to his physician, he was getting his prescriptions, and his physician decided it wasn't worth his time to manage pain anymore and told him, I will not write you prescriptions anymore. No referral, no 30 days, no nothing. He said it's too much pressure from the government to do it. So this man was also getting his Lovenox from his physician, a blood thinner. And so he walked out because he was so traumatized about the pain medicine that he'd been on for years and years and years without his Lovenox prescription. And in 2 weeks, it caused blood clots all over his body. And he ended up with kidney failure, which led to necrotizing fasciitis, which had both legs amputated. Because it was so traumatic what he was being told about this event. And so, I mean, I find that that's negligent to say that I will no longer write you a prescription. It takes 30 days to get into another doctor.
Right.
I mean, there's no way, yeah, I mean, so, and that doesn't mean it's the person who you need to talk to or all of those kind of things, at least 30 days. So to walk out and say, I'm not writing another prescription for you is really just horrible.
The gentleman I told you about, his client who wants to go to gun range with him, he was on methadone for years. And they said, you have to go off the culture. I mean, didn't give him something else. And, I mean, he had, you've seen in the movies, like someone getting off the drugs, like the cold sweats and all that, and the diarrhea and the crampy stomach and everything. That's what he went through. I mean, people going off of hydrocodone, all of a sudden they're told you just have to go off of your hydrocodone. It's awful. So the CDC has come out and said, now they have, Matthew just showed me something the CDC sent out saying, you're misperceiving what we said. Mindfulness helps with sleep, and it also helps with the time it takes to fall back asleep once you go ahead and wake up because of pain. So that's, there are different kinds of mindfulness meditation. The app that I use is called De-Stressify, D-E-S-T-R-E, De-Stressify. And it has different meditations in the first group, and there's the body scan meditation is really good to help with sleep. I went through University of Massachusetts Medical Center is the one that started mindfulness meditation for use to people with with diseases. And I went through their 7-day intensive training. And every time we did the body scan, I'm a horrible sleeper, I fell asleep. It's so embarrassing. There's eating meditation. It's also helping grounding. For example, if someone starts to really get panicky because this pain is so bad, you can go ahead and ground to where you are. Feel the seat. Feel your legs. Be in the moment. We can help people learn to do that, to stay in the moment and not go into panic because of the pain.
This is listed as one of your evidence-based interventions that you can use for chronic pain, so I pay attention to that.
And another one that's evidence-based intervention, which we're going to talk a little bit more about, is cognitive behavioral therapy, which mostly and Butler feel is matching pain, not treating it. It's interesting. When I went through the training with Butler several years ago, one of my first questions to him was, this sounds like CBT to me, what you're talking about. And he said no. And now they're coming out talking about CBT. It's really interesting. But they're saying, I don't agree with them. I've seen tremendous change using CBT. So hopefully, and also there was I forgot where this was studied, but there was a survey of mental health OT still working in mental health or psychosocial, and the #1 frame of reference they were using was CBT. So when people tell you, like a psych student says to you, or a psychologist or a counselor, what are you doing using CBT? We're going to talk about OT and CBT and why it's appropriate for us to use. Okay, there have been some studies that didn't indicate it was more effective than other interventions, but there has been support for reduction of catastrophizing, which I hate that word, like I said, and a lot of evidence for it. The insomnia, CBTI, a lot of evidence for that. So we're gonna be talking about CBT a little bit more. It facilitates an active problem-solving approach. It's an ABC model, where you have an activating event, like what happened, and then your beliefs are the B part, and C are the consequences. And you have to change your way of kind of viewing the world if you believe in CBT, because you have to change to believing that your thoughts and your perceptions produce your emotions and behaviors. So someone else cannot make you angry. It's your perception of what happened and what you're telling yourself about that causes how you feel. If you change your perception and your thoughts, it changes your feelings. You assign homework to people. You have a lot of homework from me. The last one is using virtual realities. OTs are using this more and more. So, and they're showing through studies it's not just a distraction from pain, but again, it enhances the cortical mechanism of an inhibition. So it can provide a significant amount of pain relief. So you have people do different occupations, different things through the virtual reality, and they feel doing it without pain.
Is it similar to guided visualization?
Yes. So they're very similar. The only issue that I found in looking at the literature was that the head-mounted display could be a problem with people without edema. So we just have to be careful. Might have to use another type of virtual reality. Okay. So I want to switch over to, there's the Western. I want to,
The PowerPoint for,
CBT.
yes, it's on.
And do you want to stand up and stretch for a minute? And this is the Western. It has walking, but it also has personal care, washing. How much difficulty. And they give a disability rating. I don't know. Okay.
If you just hit the, that piece, the next one over on available files, right there.
I'm not sure.
Document recovery and the second one.
Where are you?
On the side.
Oh, sorry.
Oh, is that the same one?
Yeah.
Okay. I'll go up to file and resubmit. Open. CBT.
Do you want to pause recording for just a second?
But I wrote down, edit for me.
Yeah, right under it, yeah.
Yes, it's recording, so we'll just keep it recording. Do you have enough time to get through the CBT and the activity that you want to do?
I'm hoping, because I want to do slides on the CBT. I really want to hand.
To have them have an opportunity to practice. Okay, so we have that.
So
Okay.
I'm going to hand these out.
Do you want me to hand those out as you're doing the?
Yeah.
Okay.
Let's do that.
Okay.
I think I know further.
Okay.
Is it off?
No, the recording is, the red button's still on.
Okay, we're not going to watch these.
I think I just moved it closer and closer. So, explaining it.
Did you upload the ABCs to CBT?
I did.
Did I have
We're not
to
gonna
it?
watch, we're not gonna watch.
Oh, I didn't unlink it for them, so I didn't know. I'll put the link, the ABCs of CBT and that, the pain one, I'll have those unlinked. I had them, but they were hidden from me because I didn't know if she was gonna do them in class or what she was.
I usually like to do activities, I'm sorry that you're doing so much lecture. But you all said that you felt, which I was really impressed by, that his beliefs and values on the case study was the major barrier to doing what he needs and wants to do. And unless those changed, he wouldn't be able to do things in a way that, you know, what's an example of one of his beliefs or values that gets in the way of his performance in the case study?
Like how he looks at his work and his motivations towards finishing it, and then like being his idea of professionalism and not working past certain hours and all that puts all this pressure on him. So then it's pressure on his body.
Very good. Yeah, absolutely. And an example, a good example is the client I told you about, I'm not seeing anymore with the, with the wife that passed away. He doesn't believe, he really fatigues during the middle of the afternoon, has a lot of back pain during the afternoon, but he won't rest because his wife, he says, my wife had uterine cancer and she never complained and she never rested, and so why should I rest? I won't rest, even though he's in severe pain. And then even when we were sitting in his apartment, he has a recliner, but he wasn't reclined. And I said to him, are you having any back pain right now? And he said, yes. I said, why aren't you reclined? I said, because I'm sitting talking to you, and I didn't think it was polite for me to recline. And so we can all tie ourselves up with things based on how we look at them. For a good example too is what I always say to students is I've worked with people that, unfortunately, not a lot of people who may not have done well the first time on the cert exam. Okay, first time they take it, they may not have done well. And what I've seen is a common thread is that a lot of students sit there during the cert exam and start thinking, oh my God, I'm not going to pass the cert exam. I don't know the answer to this question. I'm not going to pass the cert exam. And if I don't pass the cert exam, I'm not going to be able to practice and become an occupational therapist. And if I'm not going to become an occupational therapist, my whole life is over. And I'm like, how could you even concentrate on the questions on the exam if your brain is all the way to my life is over?
Yes.
All the way there.
Right. You went from, I don't know an answer to my life is over.
Right. Right. So, we work on changing that thinking so that we're nothing. So I'm going to talk about what is cognitive behavioral therapy and how does it fit in with an OT, what's different about us doing it. Has anyone done cognitive behavioral therapy or familiar with cognitive behavioral therapy?
Some degree. I mean, I've done sessions of it recently.
That's good. That's really good. And two, some of the prerequisite psych courses sometimes we'll go ahead and go through CBT. Okay, so as I said, the premise of it is that the way you think, or your cognition related to beliefs about yourself, events, the world, and other people cause your feelings and the behaviors. So if you change the way you think, then you can change your feelings and your behaviors. So if you go to the handout that says reflection sheet, actually, I took that out. The 10 forms of twisted thinking is a table. Everyone with me? David Burns is very famous for his book, feeling good, and the feeling good guide to happiness. And he does cognitive behavioral therapy. He also has podcasts, phenomenal podcasts. So if you ever, like if you're traveling to school and you want to listen to a podcast, it's called Feeling Good Podcast. And he talks about cognitive behavioral therapy, that one, yes. We should have,
I've seen around 20 of them, so
we
somebody
should have a whole other set of them.
So there's a total of 5 handouts?
Yes.
Yes, I
Yeah,
think
we
so.
only have 4 here, so the 5th pile didn't make it to the end.
So where did it hit?
Yeah. Oh, it was mixed in. Okay. It made it to me one time, so
Now we're ready.
sorry about that.
Okay, no. Okay, so Burns has come up with, this is the B part of the ABC, 10 forms of twisted thinking. So as we go through this, see if you can think of any of ones that you might do, or any ones that you saw in the case study. That's how I really want to spend our time, unfortunately, we're on time. All or nothing thinking. You see things in black and white categories. For example, if a situation falls short of purpose, you see it as a total failure. Do you think that Mr. S has examples of all or nothing thinking? Absolutely. If I can't go out without a hot pack on my back, I'm not going to go out. I'm supposed to be 100% or nothing. So he lives his life in misery because nothing is ever good enough.
He's gonna run 3 miles or he's not gonna walk.
Exactly. Right. Overgeneralization, you see a single negative event as a never-ending pattern of defeat. You say, this always happens to me, or this never happens. Anything with Mr. S that you picked up on in terms of overgeneralization? I think a little bit with his jobs. And people done him wrong, basically, people done me wrong. This man, I mean, lives in Buckhead. I mean, he's very, very wealthy. And you saw the 2 million, you know, he still thinks about it, ruminates about the fact that because he made this moral decision, lost $2 million in his portfolio. And he thinks bad things are gonna happen to him. Okay, the mental filter, you pick out a single negative detail and dwell on it exclusively. So I didn't get an A on that test, so I'm not doing well in the course. Or I'm not gonna be a good OT because I didn't get an A. You know, or if someone says something mildly critical, you think about it for a long time. Yes, people can relate to that, I'm
I was
sure.
about to say, that never happens, right?
Never happens. Discounting the positive. When people say good things to you, they don't count as much as the negative. That's not the case, I don't think, for Mr. S very much. But a lot of people, like the clients that I work with, domestic violence, this happens all the time. And they're very uncomfortable actually with positive. Because they're so used to hearing the negative. It can't be true. Jumping to conclusions. You interpret things negatively when there are no facts to support your conclusion. You do something called mind reading. This where you project kind of like what someone thinks about you, because you're concerned that they will think, you know, like you're not a good student or they don't want to be bothered. And that's what happens, is that you believe that that's true. When you have no evidence. Like, where's the evidence that that's true? Jumping to conclusions, he did say that his wife was getting sick of him, you know, complaining. It would be an example. He doesn't necessarily, he didn't tell me that she said, I'm sick of you. Magnification, you exaggerate the importance of your problems and shortcomings or minimize the importance of your positive qualities. Do you think Mr. S does that? Absolutely. Emotional reasoning, a lot of people do this. Assume that your negative emotions reflect the way things really are. Like if you feel guilty, you feel that you're a wrong person. So you define yourself based upon your emotions. Anyone do that? Does Mr. S do that? Things are really bad. I would say that my client, the 79-year-old, does emotional reasoning when he talks about he can't be lazy. I don't want to, something about being lazy. And his wife was never lazy, so he can't be lazy. Should statements. You tell yourself that things should be the way you hoped or expected them to be. So if they're not, they can cause guilt and frustration. So would you say Mr. S has a lot of shoulds? This is the way things should be. My body should be, I should be able to do things the way I used to be able to do them. My client, I should behave the way my wife behaved when she had cancer. She never complained. So I shouldn't complain and I shouldn't stop. She never rested, so I should never rest.
My should statement is, I shouldn't feed my children French fries. I should feed them healthy stuff. And so every time I pop something frozen into I'm like, so I'm identifying it and dealing with it. Still
Yes. Labeling is a extreme form of all enough thinking. You label yourself negatively based upon your behavior. If you make a mistake, you feel that you're a failure. So you don't get a good grade on an exam, you feel like you're a failure. Anyone relate to that? Mr. S, this is throughout the entire thing for Mr. S, yes. I mean, I don't do this behavior to 100%. I'm not good enough. Personalization and blame. When something occurs that you are not responsible for, that's not under your control, you go ahead and take responsibility for that. Against yourself or someone else. This is extreme for my clients who say, the abuse was my fault. Mr. S personalizes and blames others. He externalizes. He does not internalize. Do you see that? Okay. So I gave you all some an example of automatic thoughts, and I think I gave. I'm not sure which one I gave. I think I gave it to you in the daily mood log, the 3-column approach. So this example from me, and here's an example of the distortions. The daily mood log with a twist. Oh. This is from Burns also. So, and I have my clients do this all the time. When something comes up, when they're upset, some event comes up, or we'll work through it together. So this is what actually happened to me. I had 2 students for Fieldwork Level 2 with me this past January through March, and we went to the shelter, and we also went to family treatment court in Hall County. And they wanted to really learn to do CBT. And so I did a 2-day workshop with them. Well, the first day of the workshop, the technology fell apart. In the room we were in, we only had one room we could use, and the technology was not working. Plus, we had somebody, a former graduate, who is working at the shelter with me, who was on Zoom, and the technology was not working for her to be on Zoom. So here's an example of doing an ABC. We're going ahead and identifying some of my distortions. So the A was the upsetting event. The technology wouldn't work. And then my emotions, which is the C, was frustration, disappointment, anger. And then the B are the automatic thoughts. So the things like, I can't believe this happened, never should have happened. See, and then I have the distortions for you next to there, show you what the distortions are. Okay, so, then you have a handout called the 10 Ways to Untwist Your Thinking. Anyone have that? And let me say this. Mr. S would not be a candidate to do CBT with. Can you see that? Especially at the very beginning, one would not be able to do that. You have to really have trust and a good relationship with the person in order, because you're challenging the person thinking. And sometimes people think, like in my population at the shelter, sometimes the women feel like I'm telling them they're wrong. They could feel that way, or that what they're thinking is not valid. And that's the last thing in the world that I want them to think. So you have to have people that are motivated to do this, which Mr. S was not motivated to do this. And people that are willing to change, you know, to look at things differently. People that are willing to be flexible and not rigid. Mr. S is very, very rigid. And basically, the end of the story with Mr. S was, the intervention was I went to the physical therapist and said, just whenever he comes in, just treat him. That's all he wants. He wants you to try to fix him. You guys have to learn to accept the fact that that's what he wants. You know, that's the treatment. And that he's going to complain and say, you know, it didn't work or whatever, that's what's going to happen. And so you need to go ahead and accept that.
And then you challenge their beliefs.
Yes.
Does the fact that your patient not getting better makes you a bad therapist?
Yeah.
No.
You didn't do it as an intervention. You just felt like he wasn't doing it.
Right. And I mean, we went ahead and scheduled another session and then he canceled it. So he kind of decided to.
Didn't see the value.
And I was, at that point, like, I don't think that we're gonna be able, if I had something like I could do maybe physically with him, like, you know, that he would accept like body mechanics or something like that first, and I gained his trust and rapport with him, then maybe I could have done it. But no, no. He was too rigid. And there was a lot of pain there. And they kept saying, well, maybe we should send him to a psychologist. I said, he's not open to going to a psychologist.
Yeah.
Okay, so these are the different ways that you go ahead and can challenge your automatic thoughts to change them. So the first thing you have to do is identify the distortion, which is the automatic thoughts. Okay? And then, you know, decide which ones, and it could be more than one. As you see, like I spent so many hours planning and working on this, and I can't stand the fact that everything got ruined. It's all or nothing thinking and mental filters too. And so one thing is that one way is to examine the evidence, to say, you know, where's the evidence that because, you know, you spent so many hours planning work on this, you can't stand it. Are you still here? Are you still teaching? Are you still doing this workshop? Oh, yeah. So I guess you are standing it. I guess you are okay. Where's the evidence that everything got ruined? This workshop's going on. You found ways to do it. Did it all get ruined? No, there's no evidence. See? The double standard method is used like when you put yourself down. I'm a terrible, like labeling, I'm a terrible teacher because I wasn't able to have the workshop flow the way that I planned it to. If Professor Bono, that happened, the technology got fouled up for her, would I tell her that she's a terrible teacher? There's the double standard method. Would I tell my friend? Would you say that to a friend? No. The experimental technique is where it's very specific. He's had people, for example, who had a patient client who had panic attacks, and she was afraid that she would actually die during the panic attack, you know, because your heart was really racing. So he had her run up and down stairs and get her heart rate up, and to see that her heart racing didn't make her die. So you can do experiments. You can go out and ask people, You know, if you're concerned about someone being upset with you, you can actually ask the person, did this upset you? Or ask other people, do you think this would be upsetting? Thinking in shades of gray, instead of thinking in all or nothing, you evaluate from 0 to 100. So you can look at something as a partial success or not a complete failure. So at least I got a B. You know, I'm moving towards getting my grade versus, oh, I'm totally, you know, a failure as an OT student. Survey method is what I said to you. You can go out and ask people. You know, what people have, like if people have public speaking anxiety, they think that feeling is abnormal or shameful. They ask several friends, have you ever felt nervous before you speak? Of course, people are going to say yes. Define terms. When you label yourself inferior or a fool or a loser, you can say, what's the definition of this? Like, what does a fool mean? What does a loser really mean? The semantic methods, instead of saying should, you go ahead and substitute it would be better. It would be nice. It would be desirable. It takes away the intensity. Reattribution, you think about, like, what are the other factors? I do this a lot with my clients who blame themselves, but what are the other factors that contributed to this issue, not just me? And you do a cost-benefit analysis, like what are the advantages and disadvantages of having this feeling? I've done that a lot with clients. Mr. S would be, if he was open, a really good person to do that with and say, what are the advantages and disadvantages of you continuing to ruminate about, you know, you giving up your job and losing the $2 million? You know, let's list the advantages and disadvantages to that. And hopefully if he was, you know, reasonable, he would see there's not a lot of advantages. I know we only have like a minute left, but I want to go ahead and just go over a couple more things, talk about like, how does CBT fit in with an OT? Okay, so if we focus on barriers, right, to performing the occupation, right? Strengths to perform occupations, barriers, yes, I know you're tired. And so attitudes and beliefs about performance can be barriers to, we saw that. You all said that was the number one thing, that was the barrier for Mr. S. So where we're living here in our OTPF are applying factors and beliefs, mental functions, cognitive flexibility, insight, and performance skills, process and social interaction skills. Okay? Cognitive behavioral therapy within MOHO. Volition. It relates to volition. Thoughts and feelings about confidence, enjoyment, and values are interwoven, remember? So people want to be confident. Remember the self-efficacy scale? So it's here within MOHO. Personal causation within MOHO. People's thoughts about their capacity, their self-efficacy. We often hear statements that reflect problems with these. And so if you have feelings of less personal capacity, poor self-efficacy, this can lead to shame and fear of failure when performing the occupations. So people don't want to perform them, they don't want to take risks. So if you don't work on these things with any population, you have someone who's had a stroke, someone has a hand injury, if they're afraid of looking stupid, you need to deal with that, because they're not going to do what you want them to do. They're not going to take the risk. They're not going to believe that they perform the occupation well, like Mr. S. You know, it's not up to what it was before, so it's not well. And so we have to focus on changing attitudes and beliefs about personal capacity, self-efficacy, and therefore improved performance of occupations. So the premise is, in OT, if you help the person change the way he or she thinks, feelings and behaviors can change, and thus occupational performance. And so we help people change their attitudes and beliefs through an active problem-solving approach. Meaning, don't let anyone tell you that OTs don't do CBT.
The other thing that differs with us is not only do we do CBT as a means to an end, we do it within the means of occupation. So while we're completing, we don't sit and do as much of the interview and the table talk or the couch talk that we talk about. while we're planning our interventions and while we're doing our intervention, these thoughts and beliefs will come up. They will tell you these things. And we do it within the context of occupation.
Right.
The other thing, I'm sorry. The other thing that we do is we use occupation to help reinforce to untwist the thinking. So if you reveal something, somebody has that insight, they use occupation like reminder cards or writing out their belief systems in order to reinforce that.
Right, I use those a lot. And so, just like Professor Bunner just said, we don't do talking sessions like the psychologist and counselor does, okay? Where we're training. Now, we might do some training in it in order to, that is health maintenance. That's where it comes in the OTPF. And we do that as health maintenance, with the coping strategies for stress reduction, and for performance. But it's harder for us because, like Professor Bunner said, we have to think on our feet. When someone says something, I can't do this, I should be able to do it better, you've got to go ahead and deal with that right then during the occupation. And so, like I said, for everyone, so I thought I had that. What I do a lot is, once we challenge the irrational beliefs, then we come up with, as Professor Bono was saying, cards that have the rational on it, or the non-twisted belief, like no one can define my self-worth. For the women I work with, that is so powerful for them. They carry it around in their pocket every time they feel put down. They take it out and they actually believe it. Thank you very much. It was wonderful to meet you. I appreciate your patience as we ran over time.
Thank you.